It's sending right now.
I do not have to monitor the chat outside of the Q&A.
That's correct.
Perfect.
Are we live, Anna?
Almost.
Okay.
Just missing one. And we're live. We're good.
Good afternoon, everyone, and welcome to this afternoon's symposium on skin cancer. We will start in just a moment. We know that we have several people who have signed up this afternoon, and they will be viewing via Zoom and Facebook Live. If you'll give us about another minute, we'll let people finish loading in, and then we'll start today's presentations. Okay, we'll go ahead and start. Once again, hello and welcome to everyone. I'm Ann Garst-Taylor, the Director of Community Engagement for AIM at Melanoma, which is the parent company for AIM at Skin Cancer. I'm going to have the opportunity later on to tell you a little bit more about that foundation, but it is my job right now to thank Levine Cancer for co-hosting this afternoon's symposium. And of course, a very special thanks to Drs. Babakui and Atlas for serving as our panelists. We know that you're going to have lots of questions for today's panelists, and so I want to tell you how you're going to be able to submit those. If you are joining us today via Zoom, then what you'll do is look at the bottom of your screen. You'll see a tab down there that says Q&A. Please place your questions in there so that they won't get lost in the comment section. If you are joining us via YouTube or Facebook Live, then put your question into comments. We will grab that and place it into the Q&A here on Zoom. And with that, I'm going to pass the baton to Dr. Atlas so that she can open today's symposium. Dr. Atlas?
Thank you, Anne, for having us today. I'm Dr. Jennifer Atlas. I'm a medical oncologist here at Levine Cancer Institute, who focuses her clinical practice on cutaneous malignancies. Today, we're really going to focus on some of our non-melanoma malignancies. And I have with me here from our Levine Cancer Institute skin cancer team, Dr. Shahab Babakui, who is an oncologic dermatologist. So I'm going to have him start today with our first presentation.
So good afternoon, everyone. Thanks for introduction, Dr. Atlas. So this is a very short talk, a brief review, just touching the surface of non-melanoma skin cancers, the most common ones that we encounter. Skin cancers are most common cancer in the United States. Almost 1 out of 5 Americans will develop a skin cancer some point in their life. Everyone can get skin cancer.
For just 1 second, we don't see your screen for your slides. You could reshare that. Thank you.
Let me see. I think maybe when you took over, my sharing was stopped. Share. Okay. Screen 2. Share. Is it there?
There you go. Looks good.
Okay, good. So, and there are some myths about skin cancer. Some people think that you should only have fair skin or history of significant sun exposure to get skin cancer, but everyone from any ethnicity or lifestyle can get skin cancer. It is very important to have early detection and also prevention of skin cancer because it is mostly preventable and treatable. There are several subtypes of skin cancers: basal cell carcinoma, squamous cell carcinoma, melanoma, Merkel cell, DFSP, sebaceous carcinoma. But the most common ones are first 3, and the ones that we focus today is basal cell carcinoma and squamous cell carcinoma of skin. Risk factors for basal cell carcinoma and squamous cell carcinoma are pretty similar. Overall, higher age, male sex, history of previous skin cancers, a fair skin complex, blue light eyes, history of sun damage, significant sun exposure depending on the lifestyle, repeated sunburns, and previous skin injury. If there is a thermal burn, those scars and areas can be susceptible to develop skin cancers. Inherited syndrome, relatively rare, but we have patients with, for example, Gorlin syndrome, who develop numerous basal cell carcinoma at young age. These are some photos for basal cell carcinoma. Fortunately, 3 p.m., almost everybody has already had their lunch. So these are just some samples, just some examples to show basal cell carcinoma lesions. What you see on top left is the one that you see most of the time in the textbooks, a pearly lesion with some ulceration, rolled borders. But actually, in real practice, you can have numerous appearances for basal cell carcinoma, like a flat patch showing it is a superficial basal cell carcinoma, or lower left, you will see an area which looks like just a light color area of the skin, but actually it has morphiform basal cell carcinoma, which can be sometimes very extensive before it is discovered, and other examples. Squamous cell carcinoma is less common than basal cell carcinoma. There are different numbers in different resources. Basal cell carcinoma, for example, 3 million cases a year in US. Squamous cell carcinoma between 800K to 1 million, but it still is extremely common. Similar risk factors with basal cell carcinoma: age, gender, previous skin cancer, history of sun damage. Squamous cell carcinoma has more concerns because it can become more invasive. The risk of metastasis is higher. Medication sometimes can make people susceptible to skin cancer. For example, stem cell transplant patients who receive voriconazole to prevent fungal infections, or people with multiple myeloma or other hematological disorders who receive lenalidomide. These pills also can make you susceptible. Precancerous lesions, the areas that we call actinic keratosis or actinic damage, those typically pink scaly spots that over the time, some percentage of them can turn into squamous cell carcinoma. And organ transplant recipients, Dr. Atlas in her slides will show some other significant risk factors and group of patients who can develop a squamous cell carcinoma more than the others. The reason that organ transplant recipients develop more SCCs because of immunosuppression that they receive to prevent rejection. So overall, if a patient is not organ transplant recipient, but is on immunosuppressive therapy for any reason, like autoimmune disorders, or people who are chronically on chemotherapy, people who receive hematopoietic stem cell transplant for hematological malignancies. These are all immunosuppressed status that can make them prone to develop squamous cell carcinoma. These are some examples. On the left side, these 4 bigger pictures are SCC fully developed cancer lesions. You see they can have different features: an ulcerated large lesion, exophytic lesions on lower left, and top right is the typical hyperkeratotic plaque, which is basically a bump with some crusty area at the center. And you see here on lower lip is more susceptible to develop squamous cell carcinoma than upper lip because of more sun exposure. You should never go to a doctor with these lesions if you pay attention for skin check and trying to have early detection of skin cancer. Most of the time, they don't grow very fast, we have patients who develop skin cancers in just few weeks with rapid growth, but overall, majority of skin cancers that we see in advanced stage are the lesions that were sitting there, unfortunately, for a long time and were not checked. On the right side, these three small pictures I put to show you the sample examples of actinic keratosis. These are precancerous lesions. These are the lesions that with frequent skin check and your dermatologist can treat it for you to prevent transformation to the features that we see on the left side. So early detection is very important. There is a video from American Academy of Dermatology. Is a link YouTube here that I will ask my colleagues to showing it to you. The best option is board-certified dermatologist comprehensive skin exam. Skin self-exam is another good option that you can do more frequently at home in addition to your regular skin check by your doctor. And one of the important key thing here is skin cancer development can happen at any site. Frequently, patients have full body skin check, but breast area, genital area, preanal area are not checked because of social situation or embarrassment. They don't feel comfortable, or they think that these areas are not sun exposed, so they never get cancer. We highly recommend comprehensive skin exam at least once a year, include those areas too, or primary care physician or OB/GYN physician if patients feel more comfortable to have a same gender doctor does examination. That is also an option, just to make sure someone looks at those areas too. So I stop sharing so they can show the link.
Anyone can get skin cancer, regardless of your skin color, age, or gender. Regularly checking your skin for signs of skin cancer can help you catch it early when it's most treatable. When performing a skin self-exam, check the moles and spots in your skin for the ABCDEs of melanoma, the most serious form of skin cancer. Asymmetry, where one half of a spot is unlike the other. An irregular border. Varying colors in the spot. A diameter of over 6 millimeters. And if a spot is evolving or changing. You should also look for signs of basal cell carcinoma, or BCC, and squamous cell carcinoma, or SCC. Once you know these signs, follow these steps from board-certified dermatologists to check your skin for skin cancer. Examine your body front and back in a full-length mirror. Then, raise your arms to look at your right and left sides. Bend your elbows and look carefully at your forearms, underarms, fingernails, and palms. Look at the backs of your legs and feet, the spaces between your toes, your toenails, and the soles of your feet. Examine the back of your neck and scalp with a hand mirror. Part your hair for a closer look at your scalp. Finally, check your back and buttocks with a hand mirror. Ask someone for help if you have trouble checking hard-to-see places, like your scalp or back. Record the spots on your skin and nails, including the location of the spot and whether it has changed. If you notice a spot on your skin that is different from the others or that changes, itches, or bleeds, partner with a board-certified dermatologist.
Thank you. So I share again. Okay.
We do not yet see your slides. Now we do.
Great. So now, how can we prevent skin cancer? The principles of prevention is UV protection. We try to replace the word sun protection with UV protection or light protection, because some people think that as long as they are not exposed to sun, they are protected, but actually on a cloudy day, 5 p.m. in February, you still can get UV light. Treating precancerous lesions like actinic keratosis that frequently you might have seen your dermatologist treat some areas with freezing that we will show you. And medical prevention, taking some supplements or drugs to prevent skin cancers, that which is a very broad discussion, and we usually reserve it for some patients with high-risk skin cancers and numerous skin cancers. American Academy of Dermatology has this recommendation, which is the most important slide of this talk. Basically, 6 shade, 10 a.m. to 2 p.m. especially. This is just a broad recommendation because this is a website for everyone. But in areas like Carolinas or Florida, you probably even 9 a.m. to 4 p.m. is a better option to try to protect yourself. The best way for sun protection, I always tell my patient, is not getting sun. So that's the first one. The second one is your clothing, and the last one is sunscreen. So sunscreen is not everything. So sun protective clothing with long sleeve shirt, pants, wide brimmed hats, and sunglasses with UV protection, highly recommended. Broad spectrum, water resistant sunscreen with renewal every 2 hours if you're outside for a long time, or renewal after swimming or sweating is highly recommended. People frequently forget their feet, neck, ears, top of the head, and water, snow, sand. These are also areas that can reflect the UV and are risky environmental factors that you should be very cautious and apply more sunscreen when you go to areas with exposure to snow, sand, or water. Avoid tanning beds, absolutely, especially for risk of melanoma. If you like to look tan, you can use self-tanning product, but continue to use sunscreen. Precancerous lesions, the most common treatment is cryotherapy for those actinic keratosis lesions that I showed you in one of the pictures, topical therapy with chemotherapy creams, or sometimes combination with tertinoin, a new medication called tirbanibulin. Also, imiquimod, which is a topical immunomodulator, are used by dermatologists to treat precancerous areas. Usually, we keep this for patients who have large areas of actinic damage, sun damage on their face, head, neck area, or arms, hands, and it's not comfortable for the patient to receive, for example, 35 cryotherapies. So we do field therapy with these creams, which is frequently effective. And photodynamic therapy is another technique which is done by some practices in one session. I brought just few papers here to show the evidence in the literature. Topical 5-FU cream for precancerous lesion in a group of 930 plus patients. They were randomized to 2 groups for 2 to 4 weeks treatment with topical chemotherapy with 5-FU. 1% of people who were treated with topical cream in those actinic damaged areas, they developed squamous cell carcinoma versus 4% in control group who did not use the topical chemotherapy cream. So it is a clear evidence that field therapy can be preventive for squamous cell carcinomas. Acitretin is a pill. We rarely use it. We keep it for patients who are developing numerous squamous cell carcinomas, mostly over the years. For a patient who has only 1, 2, even 3 skin cancers a year, treated easily with topical chemotherapy or surgery, we usually do not recommend going for this medication. But for some patients who have, for example, 15 skin cancers a year, they cannot go through all these procedures. They want to do something for prevention. This is a medication that can be used. 50% reduction in one study. You see 34 patients were treated, and in a follow-up period, the number of skin cancers significantly decreased. There are blood tests that should be done, monitoring the liver function, lipid panels. So it is not a pill that you take like a vitamin supplement without follow-up. Nicotinamide, you may hear the name a lot these days. The first time in 2015, a randomized trial showed 23% reduction in skin cancers, non-melanoma skin cancers. However, in the table of the data, it showed that the burden of reduction was on superficial basal cell carcinoma or superficial squamous cell carcinoma, which are already very well behaving types of skin cancers. In high risk skin cancers, it did not have significant effect. In 2023, after 8 years, a randomized trial was performed on transplant recipients who are immunosuppressed significantly. And unfortunately, nicotinamide was not able to decrease risk of BCC or SCC in these patients significantly. Caution, if you want to use nicotinamide, don't buy niacin instead of nicotinamide. Sometimes they are sold as vitamin B3, both of them, but there are some structural differences, and the side effect profile of niacin is significantly more. And I have seen patients who purchase niacin instead of nicotinamide. Omega-3 is fish oil. People use it frequently for heart benefits. There was a small study on lung transplant recipients who received large doses of immunosuppressive medications. In this limited study with limited number of patients, it was a significant reduction of skin cancers. And last slide, just touching the surface for skin cancer treatment. The reason that I add this slide is just to show that skin cancer treatment is not just surgery, because some people think that, okay, I have a limited disease only on my skin, so I just need to take it off, which is standard of care, but many other options exist. If someone doesn't want to go through a large surgery for a large superficial basal cell carcinoma on the shoulder, they can use, for example, a chemotherapy cream, or using sometimes electrodesiccation and curettage. People call it scraping and burning in an area which is not very cosmetically sensitive. You can consider that. Sometimes for some patients who have lesions that are typically skin cancer, we have almost zero doubt that the biopsy is going to show skin cancer. Dermatologists can do a shave removal and remove the lesion at the time of the biopsy. Or freezing for some superficial basal cell carcinoma or squamous cell carcinoma. In some patients in our cancer center, if they are going through chemotherapy for other diseases, they don't want to be very aggressive, having multiple procedures. Sometimes I remove the lesion by shave removal. If the base is still positive under microscope, we give them a topical chemotherapy cream after that. So this is not for you to make decision for your treatment. I just added this slide to have this open for you. And when you are diagnosed with skin cancer, you can open this discussion with your dermatologist based on numerous factors, including age, patient's preference, comorbidities, location of the cancer, histologic site of the cancer under microscope. Multiple treatment modalities can be used. And last but not least, if there is advanced skin cancer, then systemic therapies are needed that Dr. Atlas will talk about it in more detail. Thank you very much.
Thank you, Dr. Babakouly. I am going to share my slides next. And hope everyone's able to see them. Just again to
Dr. Atlas,
we go.
they're not in presentation mode.
Are we in presentation now?
Now we are. Thank you.
Just to introduce myself again, I'm Jennifer Atlas. I'm one of the medical oncologists here at Levine Cancer Institute, and I focus on cutaneous malignancies. I'm going to discuss a little bit today treatment of cutaneous squamous cell carcinoma and basal cell carcinoma. I'm going to start with cutaneous squamous cell carcinomas. Some of what I'm going over is going to overlap a little bit with Dr. Babakouly. But just briefly starting, the incidence of cutaneous squamous cell carcinomas, as Dr. Babakouly mentioned, it's the second most common skin cancer in the US, and it makes up about 20% of our non-melanoma skin cancers. But numerous population-based studies are demonstrating that the incidence is rising. Incidence increases with age. So infrequent to see these in patients under the age of 45 without other pre-existing issues or risk factors, but incidence increases by about 5 to 10-fold in patients who are 75 or older. Ethnicity and phenotypic characteristics can make us predisposed. So fair hair, red hair, fair skin, light colored eyes, and geographic location that you live. So incidence is higher in populations living closer to the equator. Risk factors that we can see. So chronic cumulative sun exposure, UV radiation, as Dr. Babakouly mentioned, is the main environmental carcinogen in this case. Indoor tanning increases this risk for cutaneous squamous cells by up to 67%. He mentioned some of the other risk factors, immunosuppression. So whether that's from an organ transplant, so someone who has a kidney, liver, lung, or heart transplant who requires medications to keep them from rejecting their transplant, someone who has infections such as HIV or has an autoimmune condition that may require long-term steroids, these would all be predisposing factors. We also know that some of our patients who have other malignancies, so lymphomas or chronic lymphocytic leukemia, may be more predisposed to developing these. In fact, some of our patients, when we look at some of the transplant kind of databases that we have in the US, approximately 35% of patients who have heart transplants will develop a skin cancer within 10 years. And some of the transplant registries, anywhere from 5 to 100-fold or more higher risk of developing a cutaneous squamous cell carcinoma than the general population. Family history and inherited disorders, as Dr. Babakouly mentioned, may predispose. And some of the medications we take may predispose us to developing these non-melanoma skin cancers. I've listed some of them here. One that I always like to point out are thiazide diuretics. They may be photosensitizing drugs and are often drugs that are used for treatment of hypertension. So in more than 95% of patients, cutaneous squamous cell carcinoma is going to be cured by surgery alone. But in 1 to 5% of patients, cutaneous squamous cell carcinomas can develop locally advanced progression or regional metastases or even metastatic disease. Although distant metastasis, so into internal organs or distant sites of disease, is less commonly seen in this type of skin cancer, local destruction can cause physical disfigurement and functional deficits from the extent of disease into soft tissue, cartilage, and even bone. So when I'm thinking about kind of risk stratifying my patients with cutaneous squamous cell carcinoma, this is how I break it down in my head and important factors I'm thinking as far as low risk, high risk, and very high risk lesions. So location matters, whether it's an area on your trunk, extremities, or in a more sensitive area like head, neck, hands, feet, and even pretibial areas, which is the lower extremities. The degree of differentiation. So how much does it look like a normal skin cell, or how much has it kind of become poorly differentiated, not looking very much like that normal cell anymore? Is it a primary lesion, so meaning it's the first time you had a lesion there, or a recurrence of having a steroid for another health issue? Do we have a prior radiation at that site? What is the growth rate? So is it something like Dr. Babakouly said, growing in weeks, days to weeks, or something that's been there for years and had slow growth? Do we have any neurologic symptoms? Are we having changes in sensation or deficits? Are we having changes in our motor movement, especially in the face when we think in the head and neck area? And what is the depth from the surface, as well as some other vessels that can be involved. And we might get this information from either clinical exam, imaging in some cases, or biopsies. So is there nerve involvement? That's what perineural invasion means, or wrapping around the nerves, or lymphatic or vascular vessel involvement. These are all things that can help us distinguish kind of the severity or risk of the lesion. So imaging studies, which is a question I often get asked. Imaging studies are indicated when area of interest is extensive or we have identified that this is high-risk disease based on our exam, including deep structural exam where we're concerned about bone involvement, deep or soft tissues. Are there lymph nodes that are enlarged, or is there evidence that there might be neurologic symptoms or nerve involvement? Radiologic imaging is the diagnostic modality of choice for assessment of bone or to determine if lymph nodes or distant disease is present in high-risk cutaneous squamous cell carcinomas. There's a number of different imaging studies we can utilize, and it's not one size fits all. CTs, MRIs, PET scans, and ultrasounds can all be helpful in certain areas. CT, I find, is most appropriate for detection of bone invasion, cartilage, or if we're looking for lymph nodes that may be involved, whereas MRI might be best suited to look at nerve involvement or certain soft tissue structures. I cannot emphasize enough how much emphasis should be put on a multidisciplinary approach. When we've identified that we have a high-risk cutaneous squamous cell carcinoma or basal cell carcinoma, the patient's at the center of this, but there's often a lot of different people involved. That may include dermatology, which is often our first step. It may include specialized surgeons, such as a Mohs surgeon, a plastic surgeon, a surgical oncologist, which is a cancer surgeon. It may include radiation specialists, wound care, a medical oncologist who can address things from a systemic therapy or medicine approach, pharmacists, radiologists to help read scans, or pathologists to look at things under the microscope. So we really have to work as a team in high-risk lesions because often more than one of us will be involved in the participation of care with the patient and their family. Treatment options. So surgical excision is the primary modality utilized for management of locally advanced cutaneous squamous cell carcinoma. So that is the standard of care. But surgery could include multiple different approaches. It may include Mohs surgery, which allows for frozen sections to be taken during the procedure and evaluated by the surgeon to look at the tissue margin for confirmation of removal before they're closing that area, and this is done in their office. Excision could also be with peripheral and deep on-face margin assessment as an alternative to Mohs surgery, or standard excision in dermatology office or a surgeon's office that is then sent for pathology to review the margins for us. Treatment could also include radiation. For the appropriate patient, there may be an option of doing definitive radiation, which means without surgery. So indications may include reserved for kind of an older patient or who is not a surgical candidate given the location or other health issues they may be facing, someone who's declined surgery, or to control acute symptoms if there's a large lesion that has bleeding or pain associated with it. We can also sometimes use radiation as adjuvant therapy, which means post-surgery or some sort of surgical intervention. Times when I think about utilizing that or having our patients see radiation may include tumors that have a positive margin, which means up to what the surgeon could take, there are still cancer cells at the margin there that we know could become a problem if we are not able to further operate on them to get negative margins or do radiation for local control. If a patient has extensive nerve involvement, especially large nerve involvement, they may be higher risk for recurrence. So we may want to think about some radiation post-surgery, or if there's presence of microsatellosis. What does that mean? If your primary cutaneous squamous cell or basal cell is an area on the skin, and you think of that as your home base, it's like developing a new nodule or house further on the block that's separated by some normal land. So in that situation, we know we have kind of a regional problem there that may be best addressed with radiation. If we have lymph node involvement or we're having multiple recurrences in the same area after surgery, these may be other indications to include radiation as part of the plan. From a systemic standpoint, as a medical oncologist, this is generally reserved for patients who have metastatic or local regionally advanced disease. So this may mean lymph node involvement or a large lesion in a sensitive area that is not easily amenable to surgery or radiation. What are our options? Well, checkpoint inhibitor immunotherapy has been well studied now and has taken the forefront in our systemic options. So this is really harnessing the body's immune system with these drugs to rev it up to try to do the work against the cancer for us. Subsequent therapies for those who aren't candidates to get immunotherapy, treatment could include drugs such as cetuximab, which affects this EGFR pathway, which is commonly affected in some of the non-melanoma skin cancers, or we could even think about chemotherapy, although this is less often utilized given our patients tend to develop these in more advanced age, or they may require kind of organ function that may be affected, especially kidney function. And then Dr. Babakuri touched on prevention in our high-risk patients with some of the oral retinoids and nicotinamide. So for resectable disease, these are people I feel can go to surgery, but have large volume disease that surgical resection could cause significant morbidity or mortality, or this may allow for reduction in tumor burden and surgical preservation of surrounding structures, especially in the head and neck. There's now been some evidence that in clinical trials that have been very favorable for sometimes using some upfront medicine with immunotherapy in certain patients. Pulling from some of the data from the phase 2 trial that looked at giving some upfront doses with up to 4 doses of immunotherapy before surgery, we had response rates with pathologic complete response, which is what I am trying to show here on this and have circled in, of up to 51% having complete pathologic responses. This means that after they had the medicine and went to surgery, that when we looked at this under the microscope, we no longer saw any active squamous cell left behind in those patients, which is a remarkable improvement from what we've had in advanced disease before with chemotherapy or pre-existing lesions. Overall response rates, up to 68% of people could have some response to the medicine. So this has been highly encouraging and is leading to additional future studies at looking at using upfront medicine in the appropriate patients with local regionally advanced disease. Patients with unresectable disease. So who are eligible for immunotherapy, we're going to be thinking about that first. So who am I thinking of? This is patients with local regionally advanced or metastatic disease that are not eligible for curative treatment with either surgery or radiation. Our first choice is going to be to offer them immunotherapy rather than chemotherapy if they're a candidate. And we have 2 drugs available to us. One is called cemiplimab and one is called pembrolizumab. These are both immunotherapy agents that work in a similar mechanism of action. So first looking at the cemiplimab data, which was looked at first in a phase 1 and then a phase 2 trial, and the response rates looking at local, regionally advanced, and then metastatic disease were ranging from about 47 to 50%. To give you a comparison, we typically in the past had chemotherapy or targeted drugs like cetuximab working in less than 20% of patients for cetuximab and probably closer to about 10% of patients with chemotherapy. So this was a great advance and new option for us for advanced non-melanoma skin cancers, specifically cutaneous squamous cell carcinoma. And this is the results looking at the other immunotherapy drug, which was similar, anywhere ranging from about 36 to 54% kind of as far as response rates based on kind of locally advanced versus metastatic disease, with the response rates being a bit lower in the patients with the most advanced disease. But all drugs come with a risk of toxicity. And in immunotherapy, I think about kind of our immune system like it's the speedometer of a car here. So we kind of have a cruising speed and we have kind of a speed limit that our immune system operates between normally. But there are times when we introduce immunotherapy and we kind of take the brakes off of that immune system, with the goal of revving up our system to try to attack and go after these foreign cancer cells that unfortunately have gotten past the surveillance of our immune system. Unfortunately, sometimes we overshoot and we create what we call autoimmune toxicity. This is when our body is now, or our immune system specifically, is going after and causing injury or inflammation in our good organs and cells. So this happens to people who have autoimmune diseases with rheumatoid arthritis, Crohn's disease. It's their own immune system that's causing them those symptoms. So we can see similar things happen when people are on immunotherapy. So we have to remain vigilant. Some of the most common side effects we can see, they don't happen right as you're getting your infusion or right after. It usually happens after several infusions. It can occur within a few days of the first infusion, or it can occur up to a year after we've stopped medication. But the median time to onset is about 2 to 16 weeks. Some of the earliest side effects we can see involve the skin, which may include rash or itching without the skin. And some of the most common ones that we can see may involve hormone production from our endocrine glands, or what we call arthralgias and myalgias, which are joint and muscle aches and pains. But any organ system can be involved. So I've kind of put a man here to the side showing that we can have neurologic toxicities. We can see our thyroid affected, which is an endocrine gland, our lungs, liver, kidneys, any of these organs can have the potential to have inflammatory side effects. In the bowels, that could present as diarrhea, muscle aches and pains, or joint aches and pains from a rheumatologic standpoint. And we can also see fatigue and, like I said, dermatitis, which would be itching and rash. Surveillance is another common question that comes up, and Dr. Babakui did a great job of kind of going through recommended surveillance, which the backbone is with your dermatologist and full body skin checks, with regional lymph nodes being looked at as well. But 70 to 80% of recurrences or development of metastatic disease for cutaneous squamous cell carcinomas that are high risk are going to recur within the first 2 years. So we want to be extra vigilant during that time frame. And approximately 95% of those will occur within 5 years from the original diagnosis. As I mentioned, dermatology and full body skin exams is essential, as well as home self exams. And clear guidelines regarding indications of baseline and follow-up imaging for surveillance are not clearly defined, but we want to think about those for the appropriate very high-risk patients who may have nerve involvement or lymph node involvement, even in the absence of symptoms. Switching gears quickly to just briefly talk on basal cell carcinomas, many of the same incidence and risk factors are noted. This is the most common skin cancer in the US, accounting for about 80% of our non-melanoma skin cancers, shares many of the same risk factors as we discussed with cutaneous squamous cell carcinoma. So chronic sun exposure with UV radiation, which we see with tanning bed use as well, which can lead to earlier development of basal cell carcinomas. Geographic location in the country matters, closer to the equator. Some of those same photosensitizing drugs can be culprits or can predispose. Phenotypic features such, once again, as light hair, eye color, fair skin, family, inherited disorders. So one we think about with basal cell carcinoma is called Gorlin syndrome. This is one where patients will often start developing basal cell carcinomas much earlier in life, in their 20s, for instance, and we want to have a high level of suspicion. And immunosuppression, once again, so patients who are in high-risk groups like solid organ transplants who are taking medications to slow their immune system down to keep them from rejecting these transplants. Once again, thinking about kind of how I stratify low versus high risk, what are some of those warning signs that we want to maybe put you down a different track for surveillance or treatment? Well, location, trunk and extremities versus some of the high-risk areas like head, neck, hands and feet. What is the size of the lesion? Do we have clear borders to the lesion? Some of those clearly circular ones like Dr. Babakui showed you in pictures, or is it very hard to define those margins? Is this an area where we previously had a basal cell or skin cancer? Are we on some of those immunosuppressive drugs? Is it a site of prior surgery or radiation? And does it have high-risk features under the microscope? These are some of the things that we're looking for. Once again, surgery is the primary modality for most of these to be managed for localized high-risk basal cell carcinomas, which can include Mohs surgery, which is the surgery we talked about where they evaluate in office the margins before closure, or standard excisions can be utilized as well. Radiation, again, could be a very effective option for patients who are older, are not surgical candidates, or have multiple health issues that could make it difficult to tolerate surgery, or a patient who has declined surgery, or to control acute issues such as bleeding or pain in a very large lesion. Radiation can also be utilized again after surgery for patients who have high-risk features or high risk of recurrence. So tumors with positive margins that we cannot do further surgery on to make negative margins, have nerve involvement, have had spread to lymph nodes, or have had multiple recurrences of their lesion. As far as systemic options or medicine options, these are generally reserved for patients who have local regionally advanced basal cells or ones that have traveled elsewhere to lymph nodes or other organs and are not amenable to surgery or radiation. There's an oral type of medication that we use called hedgehog pathway inhibitors, and there are two different drugs out there, vismodegib and sunitinib, that work through a similar mechanism. And there is also some data in the second line to use immunotherapy with that drug cemiplimab I spoke about earlier to try to harness the immune system to do the work and take the brakes off the immune system. And there's some very limited data for the use of chemotherapy, which would be uncommon to use in this type of cancer because it generally is not very effective. So just a summary, looking at the two different pills that are available that are hedgehog inhibitors. These are oral cancer medicines. I listed the doses there. Vismodegib has been specifically studied in locally advanced and those that have had metastatic disease. Sunitinib predominantly in locally advanced disease. And I listed some timing because we do have to think about administration with food and in some cases. Vismodegib is a small oral inhibitor of the SMO, which blocks activation through the hedgehog pathway. Most of our data come from two multi-center phase 2 trials, and I just listed some of the response rates here that we can see. So for locally advanced disease, we tend to see some higher response rates than those with the most advanced disease, which would be metastatic disease here. So locally advanced disease response rates can be around 68%. Many of those are going to be partial responses, so we're shrinking the tumor and maybe making it more amenable to surgery or radiation. And some will be complete responses where we see it go away entirely. In more advanced disease, metastatic disease, the response rates are closer to 36%, with the majority of those being partial responses. There are some strategies to do intermittent dosing as well to help with toxicity. Sunitinib is the second oral molecule that has been looked at as an inhibitor of the hedgehog pathway. And once again, I included some of the response rates. The 200 milligram dose is the dose that was approved by the FDA after looking at very similar response rates between the higher dose, but more tolerable side effect profile with the 200 milligram dose. As far as side effects go, some of the most common, we can see what we call hair thinning or hair loss, which is alopecia with this. We can see fatigue. We can see taste changes, so effects on the taste buds. We can see muscle spasms or cramps, and we can see decreased appetite and weight loss. Those are the big five that I talk to about everyone who considers these oral pills. The muscle spasms or cramps, which I described similar to Charlie horses in your legs, hair thinning or hair loss, and then the decreased weight, appetite, and the fatigue. These are the things that we're going to see most often. And then just briefly to show that immunotherapy has been looked at for those specifically who have had either disease progression on a hedgehog inhibitor or have had intolerance because of side effects, or at best after 9 months of one of those oral pills had stable to disease or lack of an objective response. These were patients that were considered to go on to this trial to look at the IV immunotherapy for treatment. and response rates were seen in about 31% of patients, with most of those being disease control with stability or partial responses. And it took on average about 4 months to see those responses. Thank you for your attention, and I want to turn it over to Anne to talk a little bit about AIM, and then we'll take some questions.
Thank you, Dr. Atlas, and thank you, Dr. Babakui and Atlas, for your excellent presentations. So appreciative of them. I see that we have several questions that have come in already to our Q&A tab. I encourage people at this time to go ahead and submit additional questions. We will answer those at the end of my brief presentation. I'll just want to remind you, if you are viewing via Zoom, that you can put your questions into the Q&A tab. And if you are viewing via Facebook Live or YouTube Live, you can view those via you can submit those, via the comment section, and we will move them over to the Q&A tab. All right, I'd like to talk for just a minute about AIM at Skin Cancer, and to reintroduce myself. I'm Ann Garst-Taylor. I'm the Director of Community Engagement for AIM at Melanoma, which is the parent company for AIM at Melanoma. AIM at Melanoma has been providing educational information to individuals diagnosed with melanoma for 20 years. Last year, we launched AIM at Skin Cancer, which primarily provides education for individuals who are diagnosed with basal cell and squamous cell carcinomas. We launched our new website in January. It is designed to contain information that is both relevant and accurate. We don't want you to have to go shopping for relevant and accurate information on your diagnosis. We want you to feel that when you come to our website, you have information that you can count on so that you can make better choices for your care. The most frequently visited pages on our new website definitely center on staging, treatment, and side effect management. But in addition to those pages, I would like to tell you about 3 other noteworthy sections of our website. The first is on caregiving. We know that caregivers are involved in many of the very important decisions that their family member will make. And so we wanted to put some information on our website about how caregivers can best support the individual in their life who will be receiving care. The second is a service that we provide called Ask a Skin Cancer Nurse. We have a member of our staff, Krista Rubin. She's an oncology PA with over 30 years experience. This service is a free and confidential way for you to be able to ask questions about your treatment options, those options that are being provided to you from your care team. Krista will not diagnose you, and she would not be able to change your treatment care, but rather to make sure that you fully understand those options that are being provided to you. And lastly, I want to talk about our media library. Krista has put together some webinars based upon the questions that she's receiving from the public. And in addition to that, this is where we put copies of the symposiums like the one that you are watching this afternoon. What we do is we take the individual presentations, we edit them, and then we put them back onto our website so that they can be watched again and again. So if you have questions about AIM at Skin Cancer, if there's anything on our website that I can guide you to, I will go ahead and put my contact information into the chat so that you can reach out to me. And lastly, I want to ask you, at the end of today's symposium, we will send out a survey. We want to make these symposiums more and more informational and relevant to your needs. So if you'll take just a moment to complete that survey, that will help us to improve those services that we supply to you. And with that, I am going to turn the baton back over to Dr. Atlas and ask her to open up the Q&A session to answer those questions that have come into us live. Thank you so much.
Thank you, Anne. So I'm going to start going through some of the questions, and I may repeat some that have been sent in. So first question that I have, I'm going to send to you, Dr. Babakui. It comes across: a patient has had a dozen basal cell carcinomas or more removed from kind of arm and neck, and is wondering if there's anything that they can do to minimize scarring.
Are you hearing me now?
Yes.
Yes, but we can't see you.
Oh, my video is on, I think.
Well, we just see the top
angle
of
it
your
down
head.
a little bit.
Oh, okay. You are seeing me now?
Yes.
Okay.
Angle a little more if you can.
If you can lower your screen a little bit.
Perfect.
There we go.
Okay. Yeah, the camera was. All right. So yeah, this is a very common questions that patient ask. Unfortunately, there is no specific way to minimize risk of scarring because it all depends on the location, technique of surgery. If, for example, most of the time surgeon try to use the normal natural wrinkles to put the tumor excision site in that area. These are the techniques that they use. But overall, because we see many advertisements for many fancy, expensive products in the market for scar, but overall, there is no specific way other than just listening to your surgeon for post-operative care for healing process to let he optimize healing process. But the outcome usually cannot be affected by any specific cream or product.
Thank you. Next question we have, if my squamous cell skin cancer spreads, are there certain organs that are more likely to be affected? So it really depends on where your squamous cell carcinoma started. Where's the primary lesion? The vast majority that we see are in the head and neck area. And one of the first places we're typically going to see them spread is regional spread to lymph nodes. So for instance, if you had something on the face, one of the regional lymph nodes might be into the neck area. So we want to make sure that we're looking at lymph node sites near where the primary is. That is by far and away the most common first place to see spread if we're going to see spread beyond the skin. Other organs can have spread, so these can go to the lungs and other locations, but first they're almost always going to go to a lymph node. In the head and neck area, another place that they can go that I always like to mention is the parotid gland. Squamous cells that happen in the facial area and head and neck area can also go to the parotid gland. So those are two areas that we make sure that we focus on. We have another question that says, if I have rheumatoid arthritis or an autoimmune condition or am immunosuppressed, are there radiation or immunotherapy choices that would be safe for my basal cell carcinoma? So radiation would be a good option for someone who is immunosuppressed or has a high risk pre-existing condition that they may be more predisposed to develop side effects from immunotherapy. The other option for basal cells is to use one of those oral pills, the hedgehog inhibitors, which would be acceptable to use in someone who has rheumatoid arthritis and would minimize your risk of getting some of those arthralgias or myalgias, since someone who has an autoimmune disease on my speedometer is already operating on the high side. So my suggestion would be to possibly think about trying one of the hedgehog inhibitors first in that situation. As far as other questions, I know Dr. Babukri was kind of working on some of these, but beyond avoiding the skin, what else can I do to lower my risk of recurrence? Diet or vitamins? Are there any suggestions?
So this one, as I answered, UV protection is the mainstay still, and also early detection, because if you detect skin cancers early, they can be treated very easily. Omega-3 supplement, as we talk, is not a bad option, but these are not something that has been proven with large randomized trials. Nicotinamide, as we showed the data, is a good option, but we don't know the side effects. You're a young, healthy person, take a vitamin. with like 30 years, 20 years, we don't know about the long-term effects. So I'm not sure if this is the best option to go for that. If someone has only 3 or 4 skin cancers or 2 skin cancers a year, I think the sun protection and early detection are the best options.
And does skin cancer look different on skin of color?
The short answer is overall they look similar. In contrast to other inflammatory skin conditions that it can be very different. But ulceration or squamous cell carcinoma, I have seen 4 or 5 patients with skin of color with squamous cell carcinoma. They were not very different. Obviously, it's a darker component because of the pigmentation, but nothing very different. However, the sites are important to not to miss because, for example, feet exam frequently missed in general, I mean, comprehensive skin exam. Acral melanoma, melanoma involving the nails and feet area or hands are more common in people with skin of color. So those are the areas that should not be missed. If they see dark spots under the nails, they should seek medical attention for that. So the location is also very important.
And then last question, why aren't tanning beds safe? The question came across.
Yes.
Aren't they a safe way to get a base tan without burning?
Tanning bed has UVA and is one of the major contributor of skin cancer. So we absolutely prohibit patients to receive any treatment with tanning bed. As we mentioned, if someone wants to look tan, they can use this fake tanning creams, but also they should not forget to add sunscreen on top of it.
And I think we have come to time for today. Of course, we're happy to take any additional questions that may come in, but I'll turn it back over to you.
Well, that's all the questions that we have. And so thank you so very much. And thank you to everyone who has joined us. Once again, I want to invite everyone to visit our AIM at Skin Cancer website to find additional resources for patients and families. And thank you all and have a good afternoon. Thank you for joining us.